Good evening, and welcome to UROC Critical Conversations. I am Makeda Zulu, the Executive Director of the University of Minnesota Robert J. Jones Urban Research Outreach and Engagement Center, also known as UROC. I appreciate you making your way today, and thank you so much to the Planning Committee for making this happen. Twice a year, UROC hosts public discussions focused on university community engaged research and pressing issues of concern to urban communities. Man has never made any material as resilient as the human spirit. This is a saying by Bernard Williams, an English philosopher, and very relevant to today. This critical conversation is part of our rural-urban discussion series in which we tackle issues of concern shared by rural, urban, and suburban Minnesotans. We are Zooming to you live from 4 sites across the state, from UROC here in North Minneapolis, Beyond Brink in Mankato, Kutaska Community Action in Grand Rapids, and the Promised Neighborhood of Central Minnesota in St. Cloud. This evening, we look at the commonalities that rural, urban, and suburban people face because of Minnesota's opioid crisis. We aim to tackle questions such as, what exactly is the opioid crisis and how is it affecting Minnesotans, rural and urban, in both of those spaces? Does the epidemic look the same in rural and urban spaces? If not, what are the differences and what are the shared experiences impacting both groups? According to the Minnesota Department of Health, in 2021, American Indian Minnesotans were 10 times more likely to die from opioid-involved overdose than European American Minnesotans. And African American Minnesotans were more than 3 times more likely to die from an overdose than European American Minnesotans. According to the Centers for Disease Control and Prevention.
Audio only on the main screen, there's no visual.
Hey, I'm not sure that everyone is muted. Opioids account for more than 80,000 deaths in the US in 2021. This is a crisis we simply cannot afford to ignore. Here at UROC, affiliated assistant professor Saida Abdi of the University of Minnesota School of Social Work, in collaboration with the Generation Hope and Cedar Riverside Community Council, is working on a project that examines Somali American youth's experiences with opioids. The project is co-designed and co-led by youth, and the findings illustrate the need for culturally and linguistically responsive services for this community. Professor Abdi is one of many University of Minnesota engaged scholars working in partnership with community toward a better future, and a UROC Research Agenda awardee. What makes a desert beautiful is that somewhere it hides a well. This is by French writer Antoine de Saint-Exupéry. The panelists and the moderators of this event are wells in the desert, leading scholars, advocates, and practitioners in the areas of public health, harm reduction, and substance abuse disorders, and treatment and recovery. We thank both Dan Kane and Peter Hayden, who have been leaders in this field for over 40 years, for courageously carving out a path to wellness in a world of addiction. They have made a way for new leaders, like the ones you will hear from tonight. I am honored to introduce this evening's moderator, Eddie Krumpovich, Chair of the Minnesota Harm Reduction Collaborative, a collaborative formed in 2022, which successfully wrote and advocated for the passage of House File 2041, the nation's first legalization of drug paraphernalia and drug residues. A government affairs and grassroots level consultant, Eddie has helped write and advocate for 6 substance use, harm reduction, and mental health bills in the states of Nebraska, Minnesota, and South Dakota, as well as trained, educated, and informed community systems on various public health initiatives. When we break, this is just a part of the logistics here. When we break for small groups, know that you are invited to participate at your site. Your insight and your participation are part of community building and solution making in this conversation. Thank you. And now to you, Eddie.
Thank you, Makeda, for that wonderful introduction and for the invitation to be with some just fantastic change makers here in the state of Minnesota. It's my honor to be here. And first, I'd like to mention that my qualifications for being here, while we have successfully as a team and together in Minnesota changed the national narrative in harm reduction, and we'll talk a lot about that with our panelists tonight. My first qualification is that I'm a human of lived experience. And what that means to me is that I have been injecting, smoking, boofing, and doing methamphetamine since the age of 19. I recently had a return to use a month ago. I've been in jail recently, and that is part of what I bring to this discussion. Many of us who have participated and been incarcerated and stigmatized over the use of substances has disqualified many here in the state of Minnesota and across the nation from things like needed housing, food supplies, transportation, and family systems, which drive wedges into our communities. This was my experience recently during my incarceration, and it doesn't stop me from being able to participate in these discussions with some of our amazing panelists today. As was said, I'm a drug policy grassroots level consultant, and just to make sure that we know that I'm a consultant for the DPA and the National Harm Reduction Coalition. That is not part of my job here. So without further ado, we are going to introduce our amazing panelists today. And we'll start with Charlotte. And Charlotte, tell us a little bit about yourself. And we're glad to have you here.
Bonjour. Wam nani kwe ajajakto dam kiwanabe dunjiba nishnabe kwe. My name's Charlotte Linsfoot. My Indian name is Morningstar. I'm from the Crane clan, and I'm from Anishinaabe territory. I've been in recovery 24-ish years, had a couple relapses. I'm more geared to traditional recovery and helping the community that way.
Charlotte, thanks so much for your experience and being vulnerable and sharing with us a little bit about your recovery path, which is not only valid, it's so needed in our state. So welcome. Thanks for being here. We're going to turn over to Laura Palumbi for her introduction.
Hi, everyone. Thanks for having me here. It's really just an honor and privilege to be here with such amazing panelists and all the community members who I know are joining. So my name's Laura. I'm a pharmacist by training, and I work as an associate professor at the College of Pharmacy in Minnesota on the Duluth campus. And I have the privilege of working with rural and tribal communities to find unique solutions to substance use in each community. And been able to do this for about a decade now. And of course, each community, it looks a little differently, but we've done community forums and focus groups and worked on grants together. So I'm just honored to be here and working with all of you tonight.
And thank you, Laura. Laura's been such a huge advocate here in the state for not only bills like the paraphernalia bill, but so many others. We just appreciate having her and having her voice here in Minnesota. John, without further ado, the floor is yours.
Good evening. Good evening. My name is John Smith, and I'm from Promise neighborhood of Central Minnesota. Our organization is a community-led group that works in St. Cloud and the surrounding areas. Our footprint is unique in the sense that we have 3 counties that are located inside the city of St. Cloud. I guess lastly, I want to thank all of our attendees in person today. I'd like to thank the University of Minnesota, James and Makeda, and then I'd like to thank our fellow panelists. Thanks.
Thanks, John, for being here. And like I said, thanks to everybody who is in attendance today. Your attendance here, participation in this event, not only spreads the message of empathy and tolerance, but also shows that Minnesota is on the leading edge here of some transformative change here in this space. And we're going to talk a lot about that. And some of the concepts that we've brought to this discussion today are the disparities that exist between rural and urban centers and suburban centers in regards to the opioid epidemic. And we'll talk about that a little bit. But our first question for the panelists is, and whether this is your lived experience or your research or your work or your personal tinge or tone with opioids, what's the first thing that you think that our audience who's watching today should know about the opioid epidemic from your point of view? And this question can go to anybody.
Well, I don't mind opening up the discussion. We are, as I stated before, we're in central Minnesota, and sometimes it feels like we are an urban rural setting. And so we've seen some familiar characteristics from both of those types of communities. I will say that when we first announced this conversation, we did get a lot of pushback from the Black community because several people were concerned that opioids have devastated and been devastating to our community. And now there seems to be a lot of energy when these challenges with opioids have taken on new shapes and forms like fentanyl, but they seem to be having a bigger impact in the white community. So a lot of pushback in the beginning and a lot of dialogue before this conversation today.
Yeah, John, I want to follow up with that. One of the things that we have focused on the collaborative is Black and Brown and Indigenous communities. We discussed this, and thank you for Makeda for bringing light to this, that if you are Black, you're 3 times more likely to die of an overdose. If you're Indigenous, you are 10 times more likely to die of an overdose. It seems like these communities have been left out for a long time. What do you see as at least the start to change for these communities?
Well, for us, I think a lot of the change is going to happen with prevention and working with families. And it's almost like 2 separate tracks. And so we know that there's a lot of devastation there already. And so we just can't say it's water under the bridge. But we also have to start thinking about, how much of this do we want to be dealing with at this level in the future?
Thanks, John, for your remarks here. How about the other panelists?
Can you repeat the question?
Yeah, sure. So the original question was, from your experience, what's the first thing that the audience, at least the audience here, should know about the opioid epidemic here in Minnesota?
Well, I'll say something, I guess. It's pretty real. It's getting worse, and with the fentanyl, of course, and then we've been finding it in weed and in meth, so and heroin, and that's a lot of the needle use and overdose, and it's really affecting our people as a Native community. I think because of our past and what's happened to us and our people, and how that has like a huge impact on our future, and it's been passed on generation from generation, like the different kinds of treatment and the rapes and all this traumatic stress that's happened to our people has been passed on to each generation. And I know a lot of pain comes from that trauma, which I believe is the most reason why people use is because of that pain and to get rid of it, you know.
Yeah, that's a good point. I remember back in the day when they said cannabis was the gateway drug. We now know that the gateway drug is trauma, right? Trauma is really the gateway drug. And these communities, these Black and Brown and Indigenous communities who come in with generational and systemic trauma, oppressed by individuals who, I mean, we live on Indigenous land. So how do we best support the Indigenous community here in Minnesota during this epidemic?
Maybe get more knowledge of our culture and our religion, our practices, how close we are as a community, and how we help each other out and support each other in a kind way instead of, you know, looking down or being like better than you. And you know what I mean? Like be more on the same level as us, I guess. Because, you know, we're not as, it's just different, I guess. I don't know how to explain it. We're really connected to the earth. And when we get to our roots and our ancestors help us, we become stronger. But the only way to do that is to get off the drugs and the alcohol. And that was one of my teachings when I first came into being clean and sober. I was told that when we use, our spirit leaves our body and stands next to us. But then any spirit in the area could enter our body and make us do horrible, horrible things. And I've done that, you know, like I've used meth and heroin and whatever I could get my hands on. And I just wasn't in a good place. And I felt like I disrespected my creator and my God, you know, like, and my ancestors by using.
I appreciate you sharing and being vulnerable with us about this, for the audience and for you. So I was a high school history teacher for about 6.5 years. And to share some vulnerability with you, I know that I taught history incorrectly to many of my students, and with bias and with so much inaccuracy coming from my perspective, right? The damage that has been done by a lot of us has created this. And I know as a man who identifies as gay, I also face that pressure, right? That sort of systemic pressure that goes along with this. So I appreciate you being vulnerable and sharing, and we'll talk more about this as we go along and how to best support our tribal nations here in the state. Laura, over to you.
Thanks. No, just kind of going from where Charlotte left, I think, so I grew up in a rural community, also grew up in a house very heavily impacted by substance use. And I think one of the challenges that we all face everywhere is stigma, right? But when you grow up in a rural community and in tribal communities too, I think that it maybe has a bigger role in people's willingness to seek treatment for their substance use disorder. That was the case and it is the case in a lot of the rural communities we're working, where we're really trying to talk about how substance use disorders are not a moral failure. And really trying to educate, including our medical community, but community members as well, about how the brain changes, you know, like just some basics on substance use disorder, to really try to take the stigma out of this condition, because we know folks aren't going to want to get help or seek recovery if there's so much stigma. And then once folks enter recovery, we are really trying to work with communities to allow for people to get a second chance so that they can get employment. They can get housing. There's just a lot of barriers to people with substance use disorders from the moment they start using substances to recovery. And so some of the things we're doing in rural communities are really trying to build up the strengths of each community. So like Charlotte mentioned, there's so much strength in the American Indian community, for example. So a lot of our projects really strive to give Native people the chance to share their strengths. And we talk about culture as prevention and culture for healing too. So that's something that's maybe a little unique to our work with rural and tribal communities.
Dr. Palumbi, was this on the radar of the medical community 10 years ago, 2013? Was this anywhere near the mind's eye?
No, no. And I think honestly, it still isn't really, I mean, I think the medical community that maybe is more in tuned and making efforts to really get to know what recovery looks like and treatment looks like too. It's not just taking a pill doesn't work for everybody, right? There's just so much more to substance use and healing and trauma and recovery. And I think the medical community has been a little slow to really understand what at least our Indigenous communities have known all along.
Let's pretend that you are some czar of the medical community right now in the state of Minnesota, and you can make one change. What would that change be?
That's a really tough one. I think making treatment more accessible to more people would be really helpful for the folks that are ready to access treatment. We hear a lot from people in rural communities that there isn't a treatment facility that's anywhere near them. They can't just up and leave their families to go enter treatment. They have jobs to keep. They have children to take care of. They often don't have anyone to watch their children. And so I've met with a lot of people that would really love to seek treatment or recovery services, and they're just not accessible, especially in rural communities. So I think if I were to make some magic change, I would say really allowing more maybe non-traditional treatment options and really trying to broaden the geographical spread of the treatment facilities we have right now.
Yeah, I think that's a good point, right? We want to make sure that treatment is both accessible and choice driven, right? And many times we've had choices taken away from people who use substances. I like how Charlotte discussed earlier how that looking down on communities, substance users have forever been looked down as less than and parts of our community. And given the chance, like myself and Charlotte and others, given the chance, we can do some amazing things. And so we'll discuss a little bit about that. We'll move on to the next question. A lot of what UROC has brought to this table in a very timely discussion are the disparities between urban and rural and suburban areas. And this can go to anybody in our panel. What do you see as the similarities and the differences between substance use, the opioid crisis in these communities? Let's phrase it in a different way. So I guess what we're seeing in terms of my experience, right? Here, I've lived both in Minneapolis, and by the way, for those people who are in Grand Rapids, Minnesota, hello, I live in Grand Rapids too. It's great to be a part of rural Minnesota. And what we see are disparities between poor white communities, poor Black and brown and Indigenous communities, and there seems to be some systemic barriers that exist between us. Who would like to discuss a little bit about that?
I took a few notes on this. I thought that like my friends or your friends use and they get you hooked because you have a steady income, like you'll always come back. And then the whole COVID thing, like we didn't have any interaction with nobody for a long time. And people's issues I heard on the radio were getting worse at home, more abuse, more mental, physical, emotional abuse was going on in different homes that had issues. And so it kind of heightened probably the past traumas and made more. And small towns, everybody knows everybody. and and it's easy to get. So, but in bigger towns, it's easier to get even yet, and it's harder to get caught. But um, yeah,
Charlotte, do you notice a difference between tribal lands and even the rural communities that surround? So I live on the lands of White Earth and up here in Grand Rapids and Bois Fort and others. And what I know that from my friends, they have a very different perspective of what it's like to live both on tribal land and in rural communities. What do you see as the difference?
Huh. I feel like everybody's in everybody's business on tribal land, right? Everybody knows everybody, everybody talks about everybody, and it's not mostly good either. And I think that needs to change. But living off the reservation, I notice there isn't that much of that going on. And they pretty much stick to themselves, and there's like no knit community, get to know your neighbor, share meals. My grandma always opened up her home during the holidays for anybody that couldn't have anything to eat or didn't have a warm place to just sit by a fire or something, like have a good conversation. So I think we need to bring that back for sure.
Thanks, Charlotte. John, you mentioned earlier in your opening how the St. Cloud area is urban and rural. It feels very, like there seems to be, both of those feelings. What do you get from those communities?
Well, from the communities of color, it seems like there's so much, so it's intertwined. So much of the drug usage is intertwined with law enforcement. It almost feels like, anytime somebody's talking about, getting help or rehab or things like that, it's because they've been forced to do it through law enforcement. I probably get more feedback from communities of color about that, but for sure, I don't get that much feedback from the white community and the rural community, talking about, they've been forced to do this and maybe they felt like they didn't have a problem. One of the other things too that is, I had some data pulled up, but it seems like in the past, a lot of times, opioid was connected to heroin in the Black community. And it seems like a lot of the people were older, but now we're looking at the largest number of overdoses are happening, but from 25 to 40 or something like that. And I think even the biggest number is 25 to 35. And so I'm not sure about, where that goes in terms of race and culture. But it does seem to be a shift in terms of, the ages of people that are overdosing or being admitted to the hospital and different things like that.
Yeah, you bring up a couple good points, John. One was the interaction with uniformed officers who are first responders many times, and that relationship can be really important. To your question earlier, I do want to share with you that I've been using methamphetamine since the age of 19. It wasn't until I was 38 years old that I had handcuffs put on me. And I don't make a mistake when I mention that is probably because of the color of my skin. That long duration of use, right, doesn't exist in Black and brown and Indigenous communities. What can we do better, especially in our interactions with law enforcement? What can we do better to make sure that these issues, especially in our state, which has been sort of the epicenter for this change, what can we do better?
Well, I think we can focus on prevention and focus on family support. So we keep having tonight, we're having a lot of conversations around trauma. And I appreciate Charlotte and Laura, talking about how trauma exists in communities of color. So it's almost like there's some, where there's probably some statistical analysis that suggests that we're more likely to have some sort of substance abuse issues in our families, even if it's an extended family. So I think, providing more family supports, non-judgmental supports that come from within the community, that are run by the community and run by members of the community, I think that's one of the things that we need to see, you know, and you know, we're in central Minnesota and this is a institutional town. You know, there are more police here and, you know, we got educational institutions and lots of nonprofits, but this is probably the only conversation that I get invited to participate in around opioids or fentanyl or heroin or substance abuse or anything, because those conversations are being dominated by law enforcement, education, and healthcare. And, you know, there's a history there that tells us that those institutions struggle sometimes when they're dealing with families and communities of color. And so, you know, I guess I want to take a shameless moment and say I want to thank the University of Minnesota. I just called you out a little bit because you're a higher education institution. You know, but to have the foresight to have this group together, to have this conversation and figure out what we can do next.
Yeah, these conversations are not easy. And you bring up a fantastic point, John, is that many of the individuals, our first responders, tend to impact that initial trauma a great deal. So having these conversations with these systems and these individuals, both at the university level and the police level and the hospital level and others, are really, really difficult, but they're needed. And those conversations, I will say, are happening. It's just how do we allow them to manifest within us and change us for the better. Laura, the same question to you. So you are in Duluth, right? What do you see as a practitioner in Duluth that you maybe don't see somewhere else?
Well, I should say I really don't practice much anymore as a pharmacist, but I do work with pharmacy students and other pharmacists. I think one thing that I'd like to share when I do presentations with the community. So I grew up in Ely, that's northern Minnesota, not too far from the Canadian border. And growing up there in a small town, I always thought that drugs were not in my community. They were in the Twin Cities. And that's where all the drugs were. And, you know, we were just this perfect little town. And then I really, as I kind of learned more about substance use and got more involved in the recovery movement and treatment courts, I realized that actually where I live now, so I'm in Carleton County, and Carleton County and St. Louis County actually have some of the highest rates of overdose and highest rates of substance use disorder. And I realized then, looking at maps of the state, that our rural communities are really suffering. And I had this misconception that the people that were really suffering were all in the Twin Cities, but that's just not the case. And while we're talking about systemic barriers, I think the reason that I work in the space that I do now, I work with rural and tribal communities. I am appalled by the statistic in our state that our American Indian people are dying at a rate 10 times more than white people when it comes to opioid overdose. We are actually the worst in the nation. We lead the nation in that disparity, and that just makes me sick. So that's where I've really wanted to focus my efforts. These are my friends and my neighbors. I grew up right next to the Boys Fort Reservation, and I see a lot of times where rural and tribal communities seem to be forgotten when it comes to who's at the table, who's invited to speak at the table when there's decisions being made, laws being made, when there's committees, and when there's funding also. I think there's sometimes it's just not communicated very widely to the people that might actually be suffering the worst. So I think that's the thing that you know, that I'd like folks to be aware of too, is the importance of making sure everybody has a chance to speak up and share their experience, even if they're not right in front of us. And I think the other thing too, I'm fortunate to be a part of a lot of teams that focus on harm reduction, and there's been a lot of naloxone going out in the community, and people are asking for more and more. We know it's getting used. There's a lot of people that are thankfully using the naloxone, that's Narcan. I know this is the first time we talked about it, but it's getting used. People are needing it. And I think really in rural communities, there's challenges too, because if somebody does have an overdose, emergency medical care is a lot farther away. It is so important to get Narcan into our rural communities when people are so isolated, and to really provide education on not using alone, things like that. So those are just kind of a few things that relate to your question, Eddie.
Yeah, I appreciate that. And by the way, so in a few minutes, and by a few minutes, I mean, I think and James, you can correct me, or Michaela, you can correct me if I'm wrong. I believe we're doing a Q&A at 6 o'clock. So please have your questions ready. I know we just have a question coming up here. I'm going to do a follow-up and I'll get to Ayana's question here in a minute. You mentioned harm reduction. Naloxone is one of those tenets of harm reduction, right? That we're starting to make a push across the country. And I make no mistake that obviously I work as a harm reduction expert, right? So I have a bias. And so I'd like to lend it over to you and to you, the panel. Why is harm reduction important for our state? Laura, I'll turn to you as a follow-up.
Okay. Well, harm reduction, for those of you that maybe aren't sure what we're talking about when we talk about harm reduction. So harm reduction are basically strategies that help people that are using substances to use in a safer manner. And harm reduction is about meeting people where they're at, meeting them with care and compassion and not judgment. It's an approach. And there's different things that are included within when we say harm reduction. What do we mean? So things that could reduce the harm of somebody getting hurt or even dying from using substances. So Narcan is the one that I'm most familiar with, but there's other tools such as fentanyl test strips and xylazine test strips that we've been really trying to get into the community. These are ways for people to test their drug supply. So if they're going to use drugs, they at least can test to see if those drugs contain these deadly substances. Of course, I think John already mentioned so much fentanyl in his community. Xylazine is another new drug that's unfortunately in our state, very deadly, and it is not an opioid, but we can still test for it. So other harm reduction services would be syringe access, and there's many things that harm reduction agencies do too. So why is it important? I think it's evidence-based. I think that's always important. If you were to look at the data, you'll find that people that engage with harm reduction are more likely to stay alive, right, until they're maybe ready to enter recovery, maybe not, but people that do engage with harm reduction are actually more likely to enter recovery. And everybody enters recovery at their own rate, like not everybody is ready for recovery after their first overdose. It might be more than that. It might be a lot. And so it's really, again, like meeting people where they're at and providing them with care and compassion and a voice that cares for them and wants to support them.
Well said, Laura. And I think that you hit the nail on the head, right? Harm reduction is radically accepting where somebody is at in this moment. For some reason, for a long time, when somebody was using substances, we said the following: go to treatment, go to jail. That's making the decision for somebody, and that creates an oppositional sort of dialogue. When somebody allows themselves the choice to say, hey, I want to go somewhere, we then start to see where that science makes sense. For instance, things like methadone and Suboxone, those were very stigmatized use of medications before. Those are now gold standard medications. And when we say gold standard, everybody in the audience, gold standard means it is the most efficacious, the most effective. It is better than treatment many times to keeping people alive, which is the most important thing in order to find recovery. So we have a question from Ayana here. Lots to unpack here, but an amazing question. She says, or they say, excuse me, I wonder if there are any additional ways that we can work together to decriminalize or destigmatize users more, especially in communities of color. How can we do that? How can we destigmatize people who are using substances? I'll turn it over to John.
Boy, well, I think that, as institutions and community groups and support groups that, we need to do more information campaigns. We need to, I mentioned the challenges of being in an institutional town. Too many times, it's the most educated or the most powerful that are deciding what happens and when it happens. And NA and AA have been around for a long time, and I think we need to start leaning on some systems like that to get some people with some lived or other types of experience to help move that needle forward. I know that I've asked around, I've asked people that work at institutions. I don't even know if it's a methadone clinic in the St. Cloud area. I mean, I'm sure it's got to be, but in a month and a half, I haven't been able to talk to somebody in healthcare or anything. And so I think that stigma and that that geography thing that we're talking about today, I think because we do have some urban pieces here, the rural part of this community pushes that stuff into the ground that it's just not visible like I've seen it visible in other cities. And then one more thing, there's a huge stigma in our community. And I think we have some people that are present with us today. A lot of times people in our community, they're just ODing. They're not going to the hospital. They're not, people could be in the house with them, and I know it happens, but it just seems like that stigma that we're putting on ourselves and that we're allowing others to put on us. And we're just not getting the help that we need, when those critical situations come up. I know that was off target a little bit, but I needed to share that. Sorry.
No, you make a great point. One of the places that I know in the research that we missed the mark, John, and to everybody who is out there, is we looked at, quote, sobriety as the determinant factor, as the outcome that mattered. What we didn't realize is that harm reduction with medications like Suboxone, Subutex, methadone, here was where the research finally caught up, where those substances or those drugs, for example, those medications, those medicinals, allow people to have housing, jobs, function. They allow people the opportunity to function at a level that works. What we know is that people who are searching for just sobriety, meaning a long time in recovery, are unfortunately very, very small in percentage. So we need to make sure that we're meeting people where we're at with the science right now. And so I appreciate that. So Charlotte, how do we bring people, whether it's in the indigenous community or others, how do we bring them to the table?
Well, inviting them for sure, but one-on-one is very important. Having a sit down, I think people got to feel people out, you know what I mean, and be like a one-on-one situation. Maybe attend some meetings in the area, like be a part of the group or the community. And we do a Red Road to Sobriety here, and it really, really helps a lot. And I'm starting a healing circle Sunday. And I just wanted to touch on some stuff that was said about like the Suboxone or the Subutex or whatever. I know a lot of people like to abuse that too. And some of the users that have issues. And I think that's kind of a big deal too, like to be informed about that too, because we can abuse anything. Give us something that makes us feel good and we'll abuse it. But just monitoring things, so that that's not happening, hopefully. And I don't know. I have a few natural medicines for pain that I wanted to bring up, like red rose or dogwood, and it's actually called red willow, and wild lettuce. There's some native painkiller in those things, but they're not as addictive or harmful to your body. Yes. I think that's about it.
Thanks for sharing that, Charlotte. You bring up such a good point, is that we've stayed stuck many times in that recovery looks sort of one way, right? And when you brought up, using natural medicinals, whether you're using MAT, medicated assisted treatment, whether you're using natural medicinals, whether you're using AA, the Road to Wellbriety, or other forms of support groups, or you're going to the gym and you're working out a lot, right? Whatever works for you and your community needs to be uplifted, right? We've stayed stagnant many times into a singular form of recovery. We have an anonymous attendee who had a question about chronic pain patients. I'm going to turn it over to Laura here in a second. So a little bit of history and back note. This attendee says, can the panel speak to the chronic pain community who are also struggling beyond belief? And this is very true. In dealing with the medical community who is misusing these opioid who view us as misusing opioid epidemics. In fact, we are not. This is where the science is. Let me give a little backstory before we go into this. We all know about Purdue Pharma and what happened. And let me tell you a little bit about the fentanyl crisis. And the sad part about this story is when the Purdue Pharma integrated OxyContin into our system and really lied to a lot of the medical professionals. The medical professionals bought in to some degree. What we found was that when the United States and put restrictions on opioids, they cut them down. This was in the mid 2000s. What we know happened was that in cutting those down, something had to take their place, and fentanyl came into the picture. Unfortunately, when we took opioids off the market, something had to replace. So communities were affected, and there were two primary ones. One was the chronic pain community, who needed opioids in order to survive to the next day. And the other were substance use patients who used things like OxyContin and methadone and Suboxone to save their lives. And so both of these communities had things stripped from them. And that fentanyl crisis has a lot to do with taking away options from our community. How do we bring these two communities together is the question. And then how do we move forward in increasing access, Laura?
Well, first of all, I just want to share with the person that posted this. I see it now. It's in the answered questions. I'm really sorry about your experience. I just really feel for you, and you're not alone. As you know, there is a community. And you're right. So if you can't see the comment, we are dependent on these meds versus addicted. We need them. People have disabilities. There's lots of reasons why people are dependent on opioids. I don't have a magic answer, but I can tell you about some things that have worked with the communities that I've been a part of. And I think that these are more recognized now. There's more recognition of the role of community coalitions in addressing trends like this. So in my area, for example, in Duluth, we have a coalition that meets. It's a coalition of individuals from multiple agencies. It's a multi-pronged group. We meet together to talk about substance use in the community. There's one in Carleton County. There's one in Pine County. Most counties have some sort of community coalition like this. And so this would be a really good place to get started. I've met so many wonderful collaborators through community coalitions, and really anything good that I've ever done in my career is basically because of other people that I've met through these. But that would probably be a good place to start, is with those local folks. They're usually in treatment, recovery, harm reduction. They know the system. And they're really good at getting change made. And you really need people that can kind of be walking alongside you in this case, and trying to find specific solutions for your healthcare system. Because of course, what's going on in Duluth and Cloquet is not going to be the same as Pine County or Mankato or Blue Earth County, wherever you are. But I would say that's a good place to start, is just getting to know the people that are part of that. Public health is another really good partner. They're usually the kind of the home of these coalitions. And sometimes there's different coalitions that are part, kind of affiliated with the healthcare system too. It really depends on the community. So I think you'll probably have our contact information at the end. So feel free to reach out to me if you do feel comfortable. I know you're anonymous right now, and I understand that, but if I can help connect you with anything, I'd be happy to do that.
Thanks, Laura. And I want to empathize with the question asker as well. So for those of you who don't know, and many of you on this call do know me, I've been to 40 treatments here in the state of Minnesota. 40. The state of Minnesota has paid about $10 to $15 million for my care. And like this chronic pain patient, what I needed for my recovery was pharmacologic stimulants to treat a stimulant use disorder. I needed things like Adderall and Vyvanse for myself, for my recovery, to get and to wean down off of methamphetamine. And what we found was the same stigma that chronic pain patient was having, which was lots of no's. You can't, you're drug seeking, don't do this. And what the science is now saying is that these outcomes are being measured by abstinence. When abstinence may not be the target, the quality of life may be the target that we're missing, whatever works. So we have a couple great questions here, and we'll get to these here in a second. But in this chronic pain management question, we know that opioids and whatever substance you're using, we're using it to dull pain. What do you wish, and this goes to any of us here on the, any of you, excuse me, on the panel, what do you wish the broader public knew about opioids or pain management?
I think one of the things I'd like lots of people to know is that a lot of our youth are they're smoking and ingesting fentanyl and they don't even know it. They're putting it in marijuana. They're putting it in other drugs. And I think that everybody, you know, should have an understanding of that. I heard recently that Sherburne County has sticks that you can put inside of a bag of marijuana to tell if there's fentanyl inside of it. You know, and this is the crisscross approach that we have to solving the problem, because Sherburne is more of a rural county, but they seem to have an urban solution. You know, but I haven't heard about anything like that in Stearns or Benton County, and maybe I just don't know about it. But I would want everybody to know that so many of the illicit drugs are being cut with fentanyl.
Thanks for sharing that, John. It brings up to Laura's point, fentanyl test strips. For those individuals who do not know what fentanyl test strips are, my last time in detox, which was a while ago, my urinalysis screening came up positive for MDMA and fentanyl, and I am a methamphetamine user. And so what I know is that night could have been the last night of my life, like my brother who died from a heroin overdose. What we know is that fentanyl test strips are strips that users or systems can use in order to test what's in the substance, because the most important thing that we do here as practitioners or advocates is keeping people alive long enough so they can make those decisions for themselves. So Charlotte, what do we need to know about the pain community or substance use that we're not getting right now?
Well, when I relapsed, probably like 5.5 years ago, I was on meth and I did heroin, cocaine, all that good stuff. And then, can you hear me okay? Okay. So probably like 4 months, weeks into, no, it was months. I finally didn't want to use anymore and I was in jail. And I had a vision of some medicine that would help our people, all people, get rid of that evil spirit that comes with meth and heroin. And I've shared it with the medicine man that comes here, and I've helped a few of my friends out. But I would like to help more people, you know what I mean? And it gets rid of that evil spirit, and it also helps you recover and heal your body, your brain, gets all the toxins out of your body. Our native traditional medicines are very, very, very good and potent, strong, and healing. And I think that, you know, if I could get that out there somehow, some way, it might help. I don't know, but I got the vision for a reason, you know. So, yeah.
I appreciate you sharing that, not only perspective, Charlotte, but my best friends here in Grand Rapids are Leech Lake and Fond du Lac, and their perspective is just enormous and have been huge supports for me in my recovery, right? And I think that that is just, your points are so enormous, is that whether it's that spiritual component that some talk about or the community component, because communities that have been bonded or trauma together also heal together, right? And so many times you do not want to tell a community how best to do that. So I appreciate that question. So Laura, what about language? So I was I'll give you, for those of you who don't know, I do TikTok a lot, and my TikTok, because of the advocacy I do, and my goodness, the things that we have heard as a community on TikTok, things like drug addict, dope fiend, loser, low life, wish you were dead, all those things have been told to myself and our community. Laura, what is the language of the now, and where are we going?
Thanks for that question, Eddie. So, you know, we get asked when we do presentations in the community, what can I do? And I think that one thing each of us, and I see there's probably about 90 of us total here tonight, one thing that we can all do is think about the language that we use when we talk about substance use. And we really need to strive for person-centered language. So a person with a substance use disorder, or a person who uses drugs, maybe people who inject drugs, it's person first, because they are people first. And really, it used to drive me nuts when I worked in a pharmacy. In healthcare, we still hear terms like addict and junkie and drug seeker, and those are never appropriate. Obviously never in healthcare, but not in the community either. These are individuals, they're people first. And so really, terms that we use when we talk about substance use would be a person with a substance use disorder, or a person with opioid use disorder. Terms like addict and junkie are never appropriate. We talk about neonatal abstinence syndrome instead of addicted babies, and really talking about dependence versus addiction too. That one of our attendees brought up that terminology. One other thing to think about too is this one's tricky, because a lot of people that work in healthcare are used to using the terms clean and dirty. Sometimes they would talk about like a clean drug screen versus a dirty drug screen, but really moving to more positive versus negative, or expected versus unexpected. So it was a positive drug screen, something showed up, or it was unexpected. We didn't think there would be, and it did. And then we talk about syringes too, trying to move away from dirty syringes to used syringes, new syringes. So I think all of us, even if we can only do one little thing starting tomorrow, to make a difference, I think choosing very purposely the language you use is so impactful. And you never know, there's a lot of people that are in pain, they're struggling, they have a substance use disorder, and because of stigma and the words we use, they might never tell anybody, and they might not make it, right? So if we can be people that can be kind and generous and accepting and using person-centered language, that can make a difference for the people that we care about.
Thanks, Laura, for that. I'm going to get to John as our last question before we get to the Q&A here in a second. That's such a great point. So even as somebody who helped to write the law, right? When I was telling my story, so I would say I contracted HIV from a dirty syringe. And what I was really saying was, I'm dirty because I used a needle to inject methamphetamine. And so what I'm realizing now is that even in my own personal stories, that language has power, right? And so at that time, I used I used paraphernalia. And unfortunately, HIV was the result because I didn't have access to a syringe service program. I didn't have access to these programs which reduce infectious diseases by 50%, which increase when we wrote the paraphernalia bill, and we also expanded syringe service providers. We know that it increases treatment by 5 times the national average. So John, last question to you. What did we miss here today? Whether it's from your perspective or others. And by the way, for those who are doing Q&A, if you have a question, we're going to be doing that, I think, for the next 20 to 25 minutes. So please feel free to write it, and we're going to answer those along the way. Okay.
I don't think we really missed anything. But something came to my mind about, so many of our, people from communities of color are dependent on, subsidized housing and federal or state subsidized housing. And, I've seen so many cases where, somebody could be spending the night at somebody's house and they could get in trouble around drugs. And then those people who live in the house or are the leaseholders could be denied public housing again. And so, just along with all the other conversations that we've had, it just seems like, we need to build up some kind of momentum so that we can address some of these issues around, getting vulnerable people safe places to live and sleep and eat.
That's an amazing point, John. We talk about housing and medicine first, right? When we talk about the needs of people with substance use disorder, I want to think of it, for those of you who are attending today, think of it like this. Substance use disorder is one of the few disorders, or substance use is one of the few disorders that exists that usurps or takes over those basic essential needs, whether that's housing or food or water or shelter. We would rather in those moments use, because of the disease that we have, instead of have access to the things that we need in order to find recovery. And so we need to find housing. We need the system to start providing these essential components. So we're going to get to some of these questions here. Thank you to the panel for your amazing participation today. We're changing lives here. And thank you to all the participants who are listening, as are you. And we have some amazing questions. This first question is a doozy, so enjoy. It says, hello, I'd like to hear the panelists' perspective on how to prevent substance use disorders among adolescents in our communities. They say that they agree with the sentiment that we need to address underlying generational trauma. What other approaches do we need to have or to make with young people in our communities?
I can start that. So in our state, we have regional alcohol, tobacco, and other drug prevention coordinators. So if you Google regional ATOD Minnesota, you will see there's a whole website devoted to prevention, and each region has their own coordinator. And these folks are really well versed in the science and the data and research behind prevention. What prevention initiatives have evidence, which maybe don't, but are still, providing value. So that's a good place to start. And a lot of times they'll have trainings that community members are welcome to take to. Some things that they're working on. So we talked about culture as prevention, for example, for Native American communities. So our regional prevention coordinators are working with tribes and tribal entities on some of those. There's also positive community norms, which is really focusing on the positive within different schools. And you've probably seen some billboards for those. Those are funded through drug-free community grants. So I'd encourage you to take a look at that website and really take a look at some of the different initiatives that are out there, and really what's open to community members too, because really community members are very much needed in prevention. And a lot of our prevention folks are attending those same coalitions that I talked about in different regions. It's a really good place to kind of get familiar with what's going on and where there's needs.
Thanks, Laura, for that. I did put that in the chat. If there's a clarification on that, I put it's ATOD as in dog, Minnesota. Is that correct? Okay, great. I put that in the chat as well. John or Charlotte, what can we do to help young people?
Well, I think, go ahead, Charlotte. Go ahead. Go ahead. Ladies
Okay.
first.
Sorry. I think that going into the schools and maybe telling our stories, like, all this happened, I lost all this, I went to jail. Every time I used or relapsed, it got worse, I got something else taken away, or, somebody died in my family because of this. And just letting them know how it may be fun in the beginning, but then it really does end up in a tragic thing. And I think that might be a good thing for the kids in school.
Great point, Charlotte. Thanks. John?
Well, I want to follow up with what Laura said about community members being involved in these trainings and learning opportunities. But I think community action is one of the most powerful deterrents for our kids to start going down that path. You know, our communities are rich with history and power and community knowledge. And, you know, so many people in our communities, the communities of color, have been defined as hard to reach. And so if you have communities and families and communities that are hard to reach, you've really got to use those exceptional tools and those exceptional community members who have credibility and have those relationships. You know, and so I think community action is a huge, is something that we need to invest more in, actually. Yep. And that can look a lot of ways, you know, mentors, tutors, you know, there are a lot of things happening in schools right now, but school lets out at 3 o'clock for the most part. I don't care what you do. I don't care how many people you hire from 9 o'clock or 7 o'clock to 3 o'clock. Those kids go home at 3 o'clock and they go out into the community. And that's where our community and our community leaders can have the biggest impact. And we just need to empower and be inclusive.
Thanks, John. Nicole, amazing question coming up here. It tailors right into what John was talking about. So we're going to ask the panelists, how can we allow the community to tell us what's needed instead of us telling the community what's needed? Because it seems like it's been the opposite for far too long. How do we introduce this discussion where we actually listen first and then start participating second?
I think some communities, at least in northeastern Minnesota, again, every community is different, but we've really found value in community forums where community members attend. Before COVID, we would share a meal. If we're on tribal lands, we'll often have an elder and a traditional meal and maybe even a drumming group. So really depending on the community's strengths and interests, we come together and talk about these things, and we allow people to share their stories. Like Charlotte talked about the importance of being able to share your journey. Those have been valuable. I think they're not the only way, but I know for northeastern Minnesota, our communities that have come together and had these community forums have been able to build up their local coalitions. They've been able to kind of unite together and apply for grants and do cool projects together. So I think just finding people that are willing to take that first step in planning something, or maybe partnering with public health to do that. They're usually very good partners. That is one way that we've seen some success in our region.
John, Charlotte? We've got about 10 minutes left. So we'll sound that mini alarm there, and we'll go to the next question in a second. But anything you'd like to add to Laura's comment?
No.
I think like powwows, because there's so many people there, and traditional gatherings and teachings, but also not just work with the kids, but their parents, because they see this at home and they think it's okay. Like I grew up in an alcoholic abusive home and I thought it was okay. And, you know, if we reach out to the parents, maybe get them on board, you know, like help teach them how this could be a bad thing for them if they grew up this way. And counselors in the community, you know, just make sure everybody's aware.
Yeah, thanks a lot for that, Charlotte. So Nicole, you brought up a very personal question actually for myself. And the reason is because as a gay man, our community that used together survived together, right? So we bonded in our trauma. And I think this goes for, and I do not want to speak for any other community, but speaking for me as a gay man, I know that we survived to the next day by using substances together in our communities. In a way, it was the substances and our relationships with each other that kept us alive. And what I know for a long time is that lawmakers and politicians spoke to us about what we needed as a gay community, right? I think we're starting to turn the tide as to what the communities like the indigenous and the Black and brown communities need from us, right? And how we can begin to listen to them, right? And the other way around. So Nicole, thanks for your question. And by the way, the Steve Roman Hope Network was put on here for test strips. There were a couple of others who were, Charlotte, you have a request, by the way, to come down and speak to the community. So if you look in here, way to go, good job. Here's a great question about mental health and addiction. And so we're tending to turn away from the word addiction in the up-to-date medical community, right? We're looking at substance use disorder. And by the way, that's probably going to change in the next 5 minutes, but that's kind of what we're looking at. Mental health, substance use disorder. Are they the same? Are they different? What are they?
I think that it is a combination of all things, because mental health is really a hard thing to touch on unless you're experienced, professional. But I've taken a few classes in college, and it's helped me to interact with other people with these mental health issues. And I think it's just a collaboration of healing all of it together at the same time, because bipolar, you have all these ups and downs. When you're in recovery, you have all these ups and downs, and it might be more intensified. And I mean, we have to get everything under control, like our traditional balance in us. We have to get our emotional, mental, spiritual, and physical in good health. And I think that kind of is something that is important here too, like a part of that. So it's not just one thing that you have to stop doing or change. It's a combination of all four.
Wow, great point, Charlotte. Love that point. Awesome. So I do want to jump in on this question about mental health. And it sounds so easy, but so remember back in the 90s when we grew up with ADHD, and people were like, oh, everyone's diagnosed with ADHD. Well, that was my thought too. And I think that that's probably what our family's thought was too. And then I was diagnosed with a rather poor case of ADHD when I was about 15 years old. And let's just talk a little bit about what ADHD is. ADHD is a depletion or a lack of dopamine and norepinephrine. And so those are our go chemicals. There are reward chemicals, our motivation chemicals, and our energy chemicals. And when a child has little of those, you start to see them jump around and bounce around. That's just the body and the mind's way of trying to get them enough energy so that they have distraction issues. Well, guess what happens? When you're untreated as a child for that very thing, when you turn to be an adult, you start seeking dopamine. You start seeking that very chemical that you don't have. And so what did I do with a lack of dopamine? I started risk-taking behavior because I needed more fun to replace it. And then I eventually found the most dopamine I could, which was the form of methamphetamine. And so regardless if it was the chicken or the egg, right? Both of them kind of got us there, right? And so now it's trying to treat both. It's trying to treat the underlying mental health condition, the substance use disorder condition. Anything else, Laura or John, from that? Okay, let's move on to Michael's question. We got about 5 minutes left, I think. It says there's a news piece in the Star Tribune a while back about harm reduction programs in Portland, Oregon. It said that the public was increasing resistance to harm reduction because of the negative effects of people using substances. How's it going to work in Minnesota?
Well, I think I just saw a recent article that was reviewing so there's overdose prevention centers in different areas of the United States where those are also called like safe injection facilities, right? Or, there's different names for them, but they found that there actually was not, there's lots of concerns community members have, like maybe there will be more crime, maybe there will be more syringes in the community, maybe all of these bad things will happen, our police will be overwhelmed, and they actually did not find that. And it was featured in a pretty prominent journal. I could dig up the link and maybe stick it in the chat here. But really, I think the important thing is for us that we're all humans. And so like being human, we sometimes have our biases. We all have bias, right? We all have stigma. And our job is to work on that and figure out where are we not being fair to people. And I think looking at data and evidence to really make decisions and formulate our thoughts especially when it comes to harm reduction. Maybe it's a tough sell for us. We feel like, oh, that's just contributing to substance use. That's a really common misconception. But I think being willing to take a look at the data and the research, and there's plenty of it out there. Our major public health organizations like the CDC support harm reduction, World Health Organization. So I think it's very normal for people to be confused by it, but there's a lot of great resources out there.
Good points, Laura. I'll share some of the bare bones essentials of harm reduction here in the state, and then we'll get to John and Charlotte for the last couple comments. For example, if you use harm reduction services like syringe service providers, we're going to lower infectious diseases by 50%. We're going to increase treatment by 5 times. Officers have lower needle stick injuries. This is in the last 4 months since we passed. So I do a lot of data collection based on the paraphernalia law moving forward into next session. I want to tell you some of the things Minnesota has had happen in the last 4 months. We've seen increased participation at public health services, including syringe service providers. We just heard today from the president of the Board of Pharmacy that there is less syringe litter, because we knew that that's what the science was after this as well. We also have seen since 2021, we were one of the very few states that saw a flatlining of overdoses. We don't know what the cause is, but to Laura's point, we can probably put some assertion or some causal effect to naloxone saturation, to the amount of naloxone that's in our communities. How about you, John or Charlotte? What do you think?
Well, I think there's going to be some communities that are going to embrace the harm reduction strategies. I think it's going to be more of a challenge in the center, in central Minnesota. Maybe even northwest Minnesota. I think they'll, like I said, I don't know about a lot of harm reduction activity going on in central Minnesota today. And so, I feel like we'll probably be somewhere in the middle, just like we were with legalizing marijuana. So it's happened, but it hasn't happened. And, I don't know, 20, 25 states did it before us. And I think we'll probably be somewhere in the middle. But I expect a lot of pushback in the communities that we're in right now, because it from time to time, depending on politics and other things, it can lean to the right very heavily.
Good points, John. Much of this surrounds education, invitation, and listening, right? And so when these laws pass and things change, it's important that we know that rural Minnesota and places who have not been used to seeing these programs start having information and listening sessions to allow this. Charlotte, we're going to give the last comment to you, and then we know that people who are in-person participation are going to go into some breakout groups.
I forgot what you said now.
Oh, the question is what do we do with harm reduction? How do we increase, or how do we allow harm reduction and the science behind harm reduction to take effect in communities that don't quite have them yet?
Probably look at the numbers and the statistics. I think it's a great idea because we're helping people not get Hep C and AIDS and whatever else comes along with that. It brings an awareness to a user using, you know what I mean? And I think that helps get them thinking maybe I shouldn't do this. I think it's good. And all the bad talk about it is like, I don't think that it's a negative. And we shouldn't be negative when it comes to our loved ones or, people in the community. And we need to look up to the people that are doing good and help others and get that out there and explain it to people so they understand that we need this everywhere.
Thanks, Charlotte. And we are making a difference, whether it's the four of us who are here, the five of us who are here on this panel, or whether it's the 64 people who are currently watching. Each of us who are here are creating our own awareness of our communities. And I just want to, before we turn over to the in-person panelists, say thank you to each of you, for participating here today and saving the lives in your communities, because you're doing the work right now. And thank you for being change agents and leaders amongst Minnesotan communities, because we look up to you. We look up to your work, your recovery, and your participation with us. And so for anybody who is out there who needs information regarding anything that the panelists said, please feel free to reach out. And we will turn it over, I believe, to Makeda, so we can make some closing remarks.
So glad to be here with you all as we get ready to close. The conversation was incredible. Eddie, you are a great moderator. I don't know if you have a podcast or a show, but I would definitely listen if you had one to talk about this, because this is a conversation that needs to continue, and you've done great work in making sure that our state recognizes that we need to do things differently. And before we go into our small groups at each site, I wanted to just repeat back some of the things that I've heard. I know I can't repeat everything because you all gave such rich nuggets for us to take home. I want to start with person-centered. Person-centered. We need to recognize the person that is using and what they are using. I also, one of my favorite things that I heard tonight was the gateway drug is not marijuana, it's trauma. And I would add that it can also it can be pain, isolation, or feeling isolated. Another thing you all talked about was educational institutions, law enforcement, and healthcare are monopolizing this discussion without centering community. The question was, how can community be a part of these conversations? I think Nicole asked that question. And so I would say that the education institutions, law enforcement, and healthcare need to center community, and community needs to show up wherever they are and let them know that the solutions include, as Charlotte said, cultural practices, rituals, and knowledge, respecting that, that those are our ways out. And I know this is not going to be a conversation about reaching deeply into our roots, but each of us has culture. We have rituals and practices that tie to our ancestors, and tying into that, getting to know that can help us find our way, not to sobriety necessarily, but to harm reduction. Sobriety does not have to be the goal. I believe I heard that tonight, which is so helpful. I think that many of us find ourselves trying to understand this world. We've been close to it. We might have been a part of it in many ways. And the language that we use can be part of that stigma that doesn't allow us, to seek help. A lot of you all talked about small towns and everybody knowing everybody's business. That makes it hard to go seek help when folks know your business. And I would say that the Twin Cities is a bunch of small towns. And that is also a reason why people don't go places, because they're worried about people, worried about their business. But we know that the answers lie within us. You all showed us that tonight. My hope is that we will continue these discussions with you all. I see a lot of stuff going on in the chat. I want to make sure that I thank James for putting this together, for his tireless work. Please, let's stop and thank James DeSoto.
Thank you, James. Tireless work, tireless.
And he
Thanks,
was so
James.
excited about, yes, he was so excited about this work. And we do have similarities. And I think that the rural, urban, and suburban communities, small towns, farm towns, big cities, small cities, we can go to the state and let them know this problem is ravaging all of us. And usually, it doesn't matter the class, but I will say that those of us that have a little less pennies, we tend to struggle a little more in this area. And it's amazing. We have less pennies. We don't have as many jobs, and folks can find a way to get those substances to us. So maybe they can find a way to get some jobs and some housing to us. It looks like, I'm not sure if John has his hand raised. Oh, all right. Okay. All right. I clearly got excited by your conversation because I'm going on way too long. So please forgive me, but I enjoyed. Thank you, Eddie. Thank you, Laura. Thank you, John. Thank you, Charlotte. Thank you, James, and your entire team. I also want to let you all know that, UROC holds these conversations twice a year. In the spring, we'll be talking about birth justice. And next year, this time, we'll be talking about cancer. These are all big topics, big hairy ones that we need to talk about and find ways to solve. And you all have done an excellent job tonight. Thank you for everybody who has joined us and stayed. And for those who are at sites in Duluth, at Grand Rapids, in St. Cloud, in the Twin Cities, let's have a conversation. I look forward to seeing you all next time.